Hello, my name is Abby Atwood, and I will be presenting on the topic Maternal and Newborn Health Disparities in Alabama. Where are the midwives? Maternal health is critical to the overall health and well-being of children, families, and communities. Death during this time frame is traumatic for the family, community, healthcare providers, and others who cared for the individual who died. Maternal loss can have generational impacts. Maternal mortality is a national crisis with sobering statistics. The U.S. maternal mortality rate has increased from 17.4 per 100,000 births in 2018 to 20.1 per 100,000 births in 2019. In 2020, Alabama had the third highest maternal mortality rate in the nation at 36.4 per 100,000 live births. The underlying causes can be complex, such as access to healthcare, social determinants, and racial disparities. Another staggering statistic notes that more than 55% of deaths among pregnant women who delivered were determined to be preventable by the Maternal Mortality Review Committee. In addition, Alabama also ranks higher than the national average in percentage of low-risk cesarean birth, which is the percent of women who had cesarean births who were first-time moms carrying a single baby positioned head down, and inadequate prenatal care, which is the percent of women who received care beginning in the 5th month or later, or less than 50% of the appropriate number of visits for the infant's gestational age. The inadequate prenatal care is greatly impacted by the fact that large portions of the state are in a maternity care desert where patients must drive significant distances to obtain prenatal care. Alabama also performs poorly in regards to infant mortality. Infant mortality rates are an indication of overall health. Leading causes of infant death include birth defects, preterm birth, low birth weight, maternal complications, and sudden infant death syndrome. Alabama has an infant mortality rate of 7.2 versus the national average of 5.4. Additionally, in the 2022 March of Dimes report card, Alabama received an F, the worst possible rating, with a preterm birth rate of 13.1%. The racial disparities for newborn health is staggering, as the preterm birth rate among Black women in Alabama is 50% higher than the rate among all other women. Overall, there is a critical connection between infant health, maternal health, and the health of a family. All are dependent on their lived social context, the quality and accessibility of healthcare, and the policies within a state. Each factor can provide insight into how a state serves its population. As discussed, the United States has the highest maternal mortality rate among developed countries. OBGYNs are overrepresented in its maternity care workforce relative to midwives, and there is an overall shortage of maternity care providers, both OBGYNs and midwives, relative to birth. In most other countries, midwives outnumber OBGYNs by sevenfold. Midwives are key care providers trained to provide a wide range of services. Among these are helping to manage normal pregnancy, assisting with childbirth, and providing care during the postpartum period. Placing a priority on natural reproductive processes and relationship building, midwives also can help address the social and personal needs of mother, baby, and family. OBGYNs, meanwhile, are physicians trained to identify and intervene in abnormal conditions that come up before, during, and after pregnancy. They typically provide care in hospital-based settings. Midwifery-led models have been shown to provide care that is comparable to, or sometimes even better than, that provided by OBGYNs. The US and Canada have the lowest overall supply of midwives and OBGYNs, 12 and 15 providers per 1,000 live births respectively. All other countries have a supply that is between 2 and 6 times greater. The World Health Organization recommends midwives as an evidence-based approach to reducing maternal mortality. Several systematic reviews have found that midwifery-led care for women with healthy pregnancies is comparable or preferable to physician-led care in terms of maternal and neonatal outcomes, including lower maternal mortality and morbidity, and reduced stillbirths and preterm births, more efficient use of health system resources, and improved patient satisfaction and maternal psychosocial well-being outcomes. Experts note that high-income countries with the lowest intervention rates, best outcomes, and lowest costs have integrated midwifery-led care into their healthcare system. In the United States, midwife services are not uniformly covered by private insurance plans. This is particularly the case when services are provided in non-hospital settings like the home or a birthing center. And while the Affordable Care Act requires that state Medicaid programs cover midwifery care, the supply of providers is often so low that beneficiaries are often unable to access these services. Several factors, which can vary widely from state to state, may be limiting the supply of midwives in the United States. Among these are the state licensure laws, restrictive scope of practice laws, and rules requiring physician supervision of midwives. Alabama is noted to struggle with all of these factors. The state effectively outlawed lay midwifery in 1976. Non-nurse midwives, common in other states, couldn't legally practice again in Alabama until advocates won passage of a new law in 2017. Presently, Alabama has only about 45 midwives working across the state. Roughly half are certified nurse midwives, and the other half are licensed professional midwives who attend home births. Currently, Alabama doesn't allow nurse midwives to work independently from physicians, which plays a major impact in terms of opening and operating standalone birth centers. In shutting professional midwives out of birth centers and limiting the practice of nurse midwives, Alabama is missing an entire workforce of proven, safe, evidence-based obstetric care providers for low-risk pregnancies. The fate of birth center regulations lies in the hands of a 16-member committee that governs all Alabama public health matters. And this is where Alabama is unique to all other states and where critics take issue. That committee represents the larger State Board of Health, which is by state law composed of 7,000 members of the Medical Association of the State of Alabama, MASAA, a private professional organization of Alabama physicians. For more than a decade, MASA led medical groups around the state to fight against legislation that would allow professional midwives to legally practice in Alabama. Midwifery advocates eventually found enough champions in the state legislature to get legalization law passed in 2017. In the years since, MASA has continued to lobby against any legislation that would expand midwives' scope of practice. In addition, since midwives haven't been allowed to practice in the state for so many years, it is going to take a significant amount of time to get more of them in the rural areas. Another big barrier for the recruit of new midwives is the fact that they have to provide their own malpractice insurance, which can be a hefty financial burden when the profession already doesn't pay that much. Overall, there's a great number of challenges preventing the necessary care midwives can provide. The well-being of mothers and babies should be a top policy priority in all countries. In the United States, where maternal health outcomes are poor relative to many other parts of the world, policymakers and delivery system leaders can examine international models of maternity care to inform strategies for improvement. Better medical care and an understanding of the system of care for pregnant women, in addition to barriers, needs to be addressed. Innovative delivery models need to be developed to ensure that patients throughout Alabama have access to quality health care. Increasing the utilization of midwives can create pathways that decrease barriers for all women. In conclusion, the policies in your state matter. Addressing the maternal health crisis and racial inequities in maternal and healthcare outcomes will require a multifaceted policy approach, including addressing critical gaps in access to care, adopting and incentivizing high-value models for care, diversifying the perinatal workforce, and investing in community-based organizations. High-value care is care that reliably enables all pregnant individuals and newborns to experience healthy maternity care that addresses their health needs and preferences. Proven models of high-value care that reduce medical intervention and cost while improving outcomes include team-based models that incorporates doulas, midwives, and community healthcare workers, and culturally competent group prenatal care. An additional consideration is the expansion of Medicaid benefits for up to 1 year postpartum. Currently, Medicaid coverage ends 60 days after birth, leaving many new parents with no access to health care. Ensuring availability of care for up to 1 year following delivery is critically important to address the current maternal health care crisis, given that more than half of pregnancy-related deaths occur during this period. Evidence for the effectiveness of many of these policy reforms is strong. To achieve their potential, they will require collaboration and coordinated efforts by policymakers, community members, and providers across the nation. And that will conclude this presentation. Thank you so much for taking the time to listen.